Okay.
Okay, good evening, everyone. Welcome to the NSA resident academic session, which is powered by the academic committee of the Nigerian Society of the Anesthetists. My name is Dr. Ali Bashir Adam. I'm a senior registrar from Abubakar Tafawa Balewa University Teaching Hospital, Bauchi. I will be the moderator of today. Uh, Today, Dr. John Apam Osman, who is a senior registrar from Federal Medical Center, Asaba, will take us through anesthesia for the patient with asthma. So kindly listen and ensure you maximize the opportunity and get what we can be able to get from the presentation. As usual, we welcome all our teachers to the session, our consultants, our trainers, and then also we give thanks to the academic committee chairman who is the NSA president-elect in the person of Professor Kenneth Kalu, and also our thanks to the NSA executive, especially the NSA president in the person of Professor Alassane Dekki. So, Dr. John Apam, you'll have 30 minutes to make your presentation, and then question and comment session will follow up. As usual, please kindly ensure we mute all our mics and then change our device name so that it can reflect our name so that we can be able to capture the attendance. So thank you, everyone. Dr. John Apam, over to you.
All right. Thank you so much, Dr. Ali, and thank you for the warm welcome. Good evening, everybody. Good evening to all my colleagues, the residents, senior residents, our teachers and trainers here present, executives, and members of the Nigerian Society of Anesthetists. My name is Dr. John Afamusemene, training representative of the Nigerian Society of Anesthetists, and a senior resident in the Federal Medical Center, Asaba. And today, for our 8th residents webinar series, I'll be presenting anesthesia for the patient with asthma. I'll be using this outline. We'll discuss the introduction, the epidemiology, the pathophysiology of the disease, how it's diagnosed, how severity is assessed. We'll talk about the management of acute asthma, and then we'll go into the perioperative management, the preoperative management, intraoperative management, postoperative management, and then we'll end the discussion. By way of introduction, asthma is a common condition with reversible airflow obstruction, which is due to the constriction of smooth muscles in the airways. It is usually characterized by three distinct features: airway obstruction, airway inflammation, and airway hyperresponsiveness. Bronchial wall inflammation in itself is a fundamental component of asthma and results in mucus hypersecretion and epithelial damage, as well as an increased tendency for the airways to constrict, which is one of the hallmarks of the disease in itself. and the bronchoconstriction may be triggered by a number of different mechanisms. By way of epidemiology, in most hospitals in urban areas is one of the most common reasons for short stay hospital admissions, and the prevalence among children in Western countries is as high as 2 to 10%. The data for our own local areas are not readily available, but I think that number gives us a mirror of what we can expect. The median age of onset for asthma is 4 years of age, with more than 1 in 5 children developing symptoms within their first year of life. Asthma most likely results from an interaction between both an inherited modifier of inflammation and other environmental influences. Later, when we discuss risk factors, we'll identify some of these environmental influences. Childhood asthma tends to occur predominantly in males until puberty, but after age 20, the prevalence equals between the sexes. And the association between asthma and other atopic diseases has been well researched. This is called the atopic match. So risk factors, like we said, gender, childhood asthma is more common in males until puberty. And around that time, the prevalence equalizes, and after age 20, the prevalence between both sexes becomes around equal. And there's a strong association with other atopic diseases, like we've said. So it's also an important thing to look out for in the history and in the both when you're taking the patient's history and the family history. Allergens also play a very key role in asthma development, with increased exposure to indoor allergens, seeing also increased prevalence in these patients. Key allergens include dust mites, mold, cockroach allergens, and other pets like cats and dog skin allergens from the cats and dogs. Other infections, especially upper respiratory tract infections, obesity, tobacco smoke especially has been very strongly indicated. Exposure to tobacco smoke in children has been very strongly indicated, and also other perinatal factors, including smoking in the mothers during the pregnancy period. Asthma is characterized by episodes of recurrent wheezing, chest tightness, shortness of breath, and a dry cough. These episodes often involve variable obstruction of airway, which can result spontaneously or with treatment. By way of pathophysiology, the chronic airway obstruction seen in asthmatic patients is caused by inflammation and hypertrophied bronchial smooth muscles. This then leads to hyperinflation of the airways and air trapping within the airways. This air trapping subsequently results in a decrease in lung compliance and an increase in the patient's work of breathing. Chronic airway obstruction then leads to a ventilation perfusion mismatch, and then the dead space ventilation. This is now clinically evident as hypoxemia and further increases the work of breathing. So the decrease in lung compliance, or to take it one by one, inflammation and the hypertrophied bronchial smooth muscle will cause hyperinflation of the airways and air trapping. This chronic airway obstruction now leads to a ventilation perfusion mismatch, which is clinically evident as hypoxemia, and then further increases the work of breathing. So initially it may present as hypocarbia, but hypercarbia develops with increasing obstruction and failure to adequately exhale. This will now cause increasing obstruction and fatigue, and hypercarbia is typically a sign of impending respiratory failure. So when we are analyzing our patients or investigating our patients who present or who now have gotten to the stage of hypercarbia is a sign of impending respiratory failure. And then prolonged respiratory acidosis from the hypercarbia can lead to pulmonary hypertension, which now has implications on right-hand heart function. So patients with long-standing asthma or poorly managed asthma have a tendency or can quickly progress to some form of right heart dysfunction, which should be properly investigated in those patients when they are presenting. To classify severity, it's also important to understand the severity classifications. So generally, there's the mild intermittent, which has symptoms less than 2 times a week. as shown in the diagram in the table below. So this severity is classed by the days with symptoms, the nights with symptoms, and the measured values, the peak expiratory flow rate over FEV1 predicted, and the percentage measured. So mild persistent, less than 2 symptoms a week, mild intermittent, less than 2 symptoms a week, mild persistent, 3 to 6 symptoms a week. Moderate persistence is when the patient has at least daily symptoms, and then severe persistence is when these symptoms are continuous, and then is also delineated by the peak expiratory flow rate divided by the FEV1 predicted. So follow now understanding the now understanding this, let's talk about drug therapy. Mild asthma can be treated intermittently. So it's usually treated symptomatically. When patient has the symptoms, the symptoms are treated. So, and usually with an inhaled beta agonist, common in our area is the blue inhaler, salbutamol. And then when this now provides insufficient control, a steroid is now added, a regular inhaled steroid, such as beclometasone. So then patients who are not controlled by this regimen are now treated with a number of second-line drugs, which include a longer-acting beta agonist, salmeterol, which must be used with an inhaled steroid, or other classes of drugs, leukotrienes, ipaptropron bromide, aminophylline, or even oral steroids. In acute episodes in some patients, oral prednisolone can be prescribed and taken for 7 to 10 days, which is usually effective because we mentioned that the symptoms are caused by inflammation and other markers of inflammation. So steroid is usually helpful in these patients. So perioperatively, the drugs that are used to treat asthma should be continued, but sometimes in a different format. Further down the line, we'll discuss the asthma regimen, especially in the perioperative period. However, patients taking more than 10 milligrams of prednisolone daily would require steroid supplementation perioperatively and may also require intravenous maintenance doses until other drug is sorted. So what are the general considerations? Generally, most well-controlled asthmatics, and I'm sure most of us would experience this in our day-to-day practice, they tolerate anesthesia and surgery well. Usually, perioperative bronchospasm occurs in less than, according to the books, well, less than 2% of cases when routine medications are continued. So this patient probably has a mild intermittent asthma, not having regular issues. If these routine medications are continued, the possibility of perioperative bronchospasm is usually low. However, complication rates increase massively in elderly patients, patients over 50, patients undergoing major surgery, which again, a significant number of the patients will fall into, and those with unstable asthma. So those with persistent asthma, those with severe asthma, these patients have much more increased rates of complication. So elective surgery should be scheduled when asthma is optimally controlled in order to minimize the risk of respiratory issues. As we have established in well-controlled asthmatics, the perioperative risk is significantly less. So elective surgery should be scheduled when this asthma is optimally controlled. So this might include sending the patient maybe back for further review, or further management, further drug management until these symptoms are better controlled. In the preoperative assessment, there are important questions to ask when evaluating a patient for asthma. This includes how frequent are the symptoms, because like we've seen, this can give a pointer towards the severity of the symptoms. What is the amount and the purulence of the sputum? What is the use and effectiveness of medications? Person tells you, oh, yes, I use the inhaler, but it sometimes doesn't work. That's also an indication. Oh, does that mean that we need to step up therapy? I don't use the inhaler at all. That's also a pointer. That means this person is not on supervised care and increases the risk for perioperative complications. We also want to know the asthma triggers. Does this person know their triggers? Are they common things? Are they things that they can avoid? Also, that information is important for us when managing the patient perioperatively. We also want to know their activity level. Is the asthma inhibiting their activities of daily living? any previous history of surgery and anesthesia? How did they recover? Did they have perioperative events? Is there a history of recent upper respiratory infections? Because that could also point to a hyperreactive airway, which would now be a bad timing for the surgery. We also want to know if there are any recent hospitalizations or emergency department attendants. Oh, I came last week, but they just nebulized me. It's important because that shows that the asthma may not be as well controlled as it should be. So it's important to investigate hospitalizations, to also know if during this hospitalization that the patient had for asthma, if they required ICU admission, because we didn't go into that in depth. But yes, we all know that part of the end-term management of asthma that's non-resolving is ICU admission. So when they've done all they can in the emergency department, they can need to transfer this patient to ICU for ventilation assist, to assist the ventilation. And if we get that history from the patient, again, it's important to know because this is a pointer that the asthma is not as well controlled as it should be. It's also important outside the questions, outside the history taken, to use physical examination to assess for the condition of the patient. So we assess for wheezing. We look out for a prolonged expiratory phase, which are those signs of air trapping and airway obstruction that we're talking about. We use of accessory muscles of breathing, checking out for intercostal and subcostal recessions. We'll watch out for the respiratory rates, look out for cyanosis and other things like drowsiness. Also in the preoperative period, it's important to instruct parents because a significant number of our patients will be children. It's important to instruct parents to administer all asthma medications, including on the morning of surgery to ensure optimal treatment. And children with well-controlled asthma who are scheduled for elective surgery should not have wheezing. So a patient that has wheezing is a sign that the asthma is not very well controlled. And then that wheezing should be managed prior to the surgery. Preoperative wheezing is a very strong predictor of perioperative complications. So it's important to stabilize patients in conjunction with the pediatric medicine, in conjunction with the pediatric medical team, and anesthetize only when this patient is determined to be stable. Again, this obviously is in the context of elective surgery, because in emergency surgery, you might not have that luxury. However, it's important to weigh the options. There's no point rushing a patient to the table to go and battle airway problems when you can maybe spend a few more minutes to optimize this patient more preoperatively before you take the patient on table. So for a way of investigations, routine investigations as normal, the full blood count, electrolyte, urea, creatinine, the fasting blood sugar, urinalysis, and a coagulation profile, depending on the surgery they are going in for. Serial measurements of peak flow. This is the investigation of asthma, but it's much more informative than a single reading. Single reading is great, but it doesn't give as much information as serial measurements. So extra points if the patient has been attending clinic that's under supervised care. So maybe has been attending clinic in the respiratory or in the pediatric department, and then you have all those measurements of peak flow. It's important to inquire about it, or at least try and investigate or get the readings of those. Spirometry also gives an accurate assessment, and the results of these respiratory investigations, such as peak flow, spirometry, they should be compared with the predicted values based on age, height, and sex. Blood gases are not usually necessary and are only really necessary in assessing patients with severe asthma. So patients who have poorly controlled asthma, severe asthma, the symptoms are continuous, or having frequent hospital admissions, or have had a previous recent ICU admission, these patients could need blood gas analysis prior to major surgery to have a better ideation of their current clinical condition. Also, we can have baseline electrocardiogram and chest x-ray, which will be helpful for a severely asthmatic child who could have, like we said earlier, chronic airway obstruction that has led to right heart strain and maybe pulmonary hypertension. So in children like that, a chest x-ray and possibly a baseline electrocardiogram would be important. By way of treatment, Treatment preoperatively for mild intermittent and mild persistent involves a nebulized beta-2 adrenergic agonist. So salbutamol, 1 to 2 hours prior to surgery. In some centers, you can even have it there in the recovery room. So before the patient enters, they get the nebulization, and at least that is some treatment for the airway. Pre-operative treatment for moderate persistent asthma would involve additional optimization with inhaled anti-inflammatory agents, which will suppress the inflammatory cytokines. And this can be by consistent use of nebulized beta-2 agonists for up to 1 week prior to surgery. So the patient has moderate persistent asthma. They can need to be nebulized for daily for a week, pending up to that way. So that reduces the, like we said, it's very important to optimize these patients prior to that surgical day. So that could be an option for them. Preoperative treatment for severe persistent asthma would involve a visit to their primary care physician. So if they are seeing the respiratory, if they are seeing the pediatrician, whoever the primary person managing their asthma is, has to also review and optimize treatment. So they could also benefit from, they could now need more than just nebulization. They could also now turn to maybe an oral short-term corticosteroid therapy, which would be very helpful in the immediate preoperative period. So these are some classes of drugs which are used to treat asthma, examples, and how it is continued during the preoperative period. Beta-2 agonists are the mainstay of therapy, salbutamol, salmeterol, and in the preoperative period, I mean, same thing, but we can convert to the nebulized form. Note that higher doses may lower potassium concentration in the blood and can cause tachycardia and tremor. However, still the mainstay of therapy and the most quickly recommended. Anticholinergic drugs are also there, ipratropium bromide, but for this will be converted to nebulized form in the preoperative period. Inhaled steroids are also an option, and this can even be continued in the inhaled formulation up to the perioperative period. However, note that if the patient is on high dose steroids, whether inhaled or oral, adrenal suppression may be present, and then we have to take that into consideration. One way to do that is to continue as IV, so to convert any steroids that the patient is having into IV hydrocortisone, which will now be continued on the patient is back to taking orally. Some patients might require leukotriene inhibitors, although this will generally be discontinued around the surgical time and then will be restarted when taking medications. While those patients who are already or getting mast cell stabilizers will need to continue this by inhaler. Okay, so choice and conduct of anesthesia. Now we've tried to discuss asthma, the preoperative period, and the drugs that these patients are normally taking. When this patient now, when we've finished reviewing, we are considering the choice and conduct. Generally, especially for cases that are amenable to regional, it's very important to consider regional anesthesia as the stool technique, because this will completely prevent the need for airway instrumentation. I don't think it needs to be said, but I'll still say that please remember that whenever you're doing, even if it's a sole regional technique, you must have all the facilities for endotracheal intubation and airway management. So the first point is to consider, is this surgery amenable to regional? Maybe it's a lower limb surgery, maybe it's an arm surgery that you can do a brachial plexus block. There are very many options, and then if it's amenable to regional, you can have regional for the patient. It's important to have a thorough understanding of the physiological agent of each anesthetic drug. What does the drug do to the body? Because its interaction with the asthmatic patient is very crucial. So patients with active bronchospasm should be treated very aggressively. Supplemental oxygen, aerosolized beta-2 agonists, and intravenous steroids. In the preoperative period, midazolam is a generally safe anxiolytic because it does not alter bronchial tone. And H2 receptor blockers are generally best avoided. Excuse me. Intraoperative management. So here we'll talk about the agents one by one. For intravenous agents, propofol generally, so for induction, propofol generally inhibits bronchial constriction and increases central airway dilatation by directly relaxing the airway smooth muscle. So it's a drug that is regularly used in asthmatics with no adverse effects, especially for the asthmatic patients. Ketamine also is a drug that can be used because it has sympathomimetic bronchodilatory properties and has a direct action on the bronchial smooth muscle. This causes a relaxation of bronchial musculature and can be very helpful in this patient. Thiopentol has been associated with bronchospasm. Therefore, especially with the advent of these other two drugs, propofol and ketamine, is not a good first choice, especially for the induction of anesthesia, because perioperatively, we expect airway events to happen either at induction, usually at induction or at emergence. So it is not a great choice for induction because it has been associated with bronchospasm. Morphine causes histamine release. So this histamine release can trigger bronchospasm, so also not a great drug. Lidocaine, when given intravenously, increases the histamine threshold. So increases the level at which histamine, the released histamine will evoke a response, and it also can obtune the cough reflex. So it is encouraged and could be given as an adjunct or as a drug to obtain the pressure response in addition to managing the asthmatic patients. For inhalational agents, halothane, sorry, excuse me. Halothane is a potent bronchodilator, also enflurane and isoflurane. They act by beta adrenergic receptor stimulation. However, note that isoflurane especially is irritant to the airway. So it is not great for induction. However, for maintenance, it is not so bad. Sevoflurane also has controversial effects in asthmatics, although this is not complete. Some studies have shown an increase in airway resistance, while a lot of other studies have shown no change. So for sevoflurane, it is neither here nor there. If it's your regular, you can keep using it, especially now that some of the more usual agents, such as halothane, has been discontinued. Desflurane, like isoflurane, is very pungent, but in addition, it is very irritable to the airway and has been shown to increase secretions, coughing, and laryngospasm. For muscle relaxants, the neuromuscular blockers that stimulate M2 and M3 muscarinic receptors evenly do not cause bronchoconstriction. So drugs such as becuronium, rocuronium, and pancuronium, they do not cause any bronchoconstriction. They are great drugs for this group of patients. However, atracurium, mivacurium, they dose dependently. So the more you give, the more they release histamine. They release histamine dose dependently, and thus can trigger bronchoconstriction. So for airway management, airway manipulation, particularly in the light plane of anesthesia, is a potent stimulus of bronchospasm. So laryngospasm, bronchospasm, coughing, breath holding, any airway manipulation done in this group of patients is a potent stimulus for those airway events. The use of an inhaled beta-2 agonist just before intubation can help reduce bronchospasm. So like we said, in the recovery period, the patient can get nebulized before getting into the operating suit. However, if patient can also be on table and just have a okay, thank you. Sorry, I was looking at the comments. So patient can also be on table and maybe have their inhaler. So take a few puffs on their inhaler before the induction of anesthesia. That is also an option. So for short cases, a face mask may be sufficient. So whenever possible, avoidance of endotracheal intubation is preferred, because the more invasive the airway management technique, the more likely you are to trigger airway events. So if the case is amenable to a face mask or an LMA, it can be used. If endotracheal intubation is necessary, it's important to ensure a deep level of anesthesia. So patient is properly induced before airway instrumentation. So before you even scope, you're certain that this patient is properly induced, properly relaxed before you start your airway instrumentation. It's also important to know that a tracheal tube that's too long is also a potent cause of bronchospasm. So you finish intubating, you don't place it, it's supposed to just sit before the carina. So if it maybe is too long, touching the carina or stimulating any of the lower airways, it could trigger bronchospasm, and therefore the length of the tracheal tube should be carefully assessed by how we do it, either serial auscultation or whatever process is used in our various centers. Intraoperatively also, like we said, the inhalational agents generally help to dilate the bronchioles and prevent bronchospasm, and vigilance is needed to prevent intraoperative bronchospasm. Intraoperative bronchospasm will present as a prolonged expiratory phase with increased airway pressure, hypoxia, and an upsloping in the end-tidal capnography waveform. This can also result in difficulty in ventilation. So that's why this graph is here. You can see the characteristic shark fin appearance. This is the classic side of bronchospasm, especially in patients when we are monitoring patients using a capnograph. The upsloping in the end tidal waveform, the increased airway pressures are all pointers to bronchospasm and can result in difficulty with ventilation. So while we see these two, other causes of airway obstruction should be ruled out before prior to initiation of treatment. Initiation of treatment will be by a short-acting inhaled beta-2 agonist, such as albuterol or salbutamol. The first intervention for intraoperative bronchospasm is to remove the causative stimulus. So if it's maybe light plane of anesthesia, you can dip in anesthesia. If it's airway instrumentation in a light patient or whatever the identified causative stimulus, it could also be drugs. Like we talked about some drugs that release histamine, while increasing the FiO2. So the treatment will now be remove the causative stimulus, increase the FiO2, increase the expiratory time to allow more time to vent the gases and prevent air trapping and deepen the anesthesia. The waveform of the end tidal is an early indicator of the effectiveness of these interventions, because the same way these waveforms present in a characteristic shark fin appearance, when you start to initiate your treatment, you give the beta-2 agonist, you adjust the inspiratory-expiratory ratio, and then increase the FiO2, the capnograph will start to normalize. So that also shows you an early indicator of the effectiveness of your intervention. So how do we manage severe bronchospasm? We'll talk about in theater or out theater, which is the normal, let's say, regimen, and then we'll talk about bronchospasm on table, and then we'll conclude. So management of severe bronchospasm outside of theater. First is important to start high flow oxygen to improve oxygenation, prevent hypoxemia, and prevent hypercarbia. It's also important to gain IV access as early as possible, because some of these treatments might now get to a point where you need IV access. So the earlier you start to initiate that process, the better. Nebulized salbutamol is generally the mainstay and can be given continuously as 5 to 10 milligrams per hour. Alternative is to use a metered dose inhaler, preferably with a spacer, because this increases the amount of drug that actually gets to the patient. We can also use nebulized. If that doesn't work, nebulized evaporation bromide, 0.5 milligram, 4 to 6 hourly. If the salbutamol is not responding, if the nebulized salbutamol patient is not responding to that, we can give IV salbutamol, usually as a 250 milligram slow bolus, then 5 to 20 micrograms per minute. Hydrocortisone steroids can also be employed, 100 milligrams IV every 6 hours, or if the patient can tolerate orally, prednisolone orally. If doesn't fail to respond to any of this, we all know magnesium can be used. 2 grams can be given intravenously over 20 minutes, and then the response is analyzed and see if you need another dose. Aminophylline can also be given 5 milligrams per kilogram intravenously in an infusion. This may be effective. However, if there's decreasing consciousness levels, adrenaline can be used, both nebulized or intravenously. And note that this can cause arrhythmias, so especially in the presence of hypoxia and hypercapnia. If intravenous access is not available at the point, intramuscular or subcutaneous adrenaline could now be given, although the absorption is unpredictable, especially due to poor perfusion in these patients who are already getting critical. So if this bronchospasm, however, happens during anesthesia, it's good to know that most of our volatile agents are bronchodilators, so they are effective under anesthesia. This is also a reason why, like we said earlier, in patients who are not severe, there's generally a low risk of perioperative events. So, however, if bronchospasm occurs, which usually commonly occurs immediately following intubation, we can switch to 100% oxygen and stop all potential anesthetic precipitants. So we talked about them earlier. Maybe you're giving morphine, maybe you're giving atracurium, maybe patient is in light plane and you're giving isoflurane or whatever thing is irritating the airway. Switch to 100% oxygen, stop all potential anesthetic precipitants, confirm that the problem is bronchospasm. So take a quick look at your circuits, make sure there's no kinking, no problems with the endotracheal tube, or problems with your monitor that are giving you a wrong reason. You can then ventilate with the appropriate inhalational agents to cause some form of bronchodilation. So halothane, isoflurane, sevoflurane. It's important to note that you might need high inflation pressures because of the bronchospasm. Bronchospasm will mean high respiratory pressures, so you might need high inflation pressures. This could mean a sustained positive pressure on the bag if you're manual ventilating, or you can even, if you are mechanically ventilating, see that your peak airway pressures are higher than they normally are. However, note that there will be impaired expiration due to the airway resistance, and this will result in the over distension of the alveoli, which will cause auto PEEP. It's important because, most machines will also show you a reading of the auto PEEP or the current PEEP of the patient, and that will give you a pointer as to whether you should maybe adjust like we talked about earlier, the inspiratory-expiratory ratio to give more time to vent the airways. So to avoid auto PEEP, you use a slow respiratory rate and also allow for expiration to take place. So that's the point we said about changing the inspiratory-expiratory ratio. Normally for most machines is maybe 1:2 or 1:1.5 or 2.5. I now extend that 1:3, 1:3.5, depending on what your parameters are and what you're seeing on there. Then you can also give salbutamol inhaler through a special adapter. We'll just quickly talk about that. This is an example of the adapter that can connect to an endotracheal tube. So if this is unavailable, if no adapter is available, you can put the inhaler into the barrel of the 50 ml syringe. You can see it here. And then you attach the syringe via a lower lock to 15 cm of infusion, which can now be fed down the endotracheal tube. So to rehash, get a 50 ml syringe, you put the inhaler in the barrel and then connect it to a tubing. This tubing can be put down the endotracheal tube, and then when this plunger is pressed, the drug is now directly deposited down the endotracheal tube. So this is a fabrication of what we can use, but the ideal adapter that attaches to the ETT looks like this diagram up. I'm sure you can see my arrow. So discharge 2 to 6 puff by downward pressure on the syringe, and then as an emergency measure, if you don't have this, you can just discharge the inhaler directly into the ETT and then reconnect the circuit and ventilate. Obviously, if this is not working or have limited response, You can then use the IV drugs, like we said above, the steroids, the drugs as usual, and continue doing that until the bronchospasm is averted. And then important to avoid halotane if we have gotten to the point where we are using adrenaline, because just a reminder, the halotane sensitizes the heart to the catecholamines. So if you have gotten to a point where you are now having to use adrenaline to reduce the bronchospasm, you can cut the patient off from halotane and maybe use IV ketamine to maintain anesthesia during that period. So that's intraoperatively. For extubation, because like we said, if airway events are going to happen, they usually would happen at intubation or at emergence. So for electric surgery without complications, you can choose to extubate the patient deep, because deep extubation has been seen to prevent laryngospasm when the endotracheal tube is removed. However, for emergency surgery, especially those also with full stomach or also other considerations, an awake extubation is a much preferred option. This occurs after the airway reflexes have returned, and then the patients can protect their airway. So sufficient amount of opioid and even another dose of the inhaled beta-2 agonist may be useful prior to extubation in these circumstances to decrease the reflex bronchoconstriction that may occur. It's good to also remember that our antagonists, neuromuscular antagonists, neostigmine, can cause increased secretions. So always good to give with glycopene as usual to reduce the secretions and the bronchial hyperactivity that comes with it. In the immediate post-op, pain relief is very important, because pain relief can also be a trigger for bronchospasm and other asthma events. So whether you're using regional, you're using opioids, ketamine can even come into play. And NSAIDs also, although controversial, can be used depending. Also, in the immediate post-op period, or in patients who are receiving opioids or an epidural, we can want to prescribe oxygen in that immediate post-op period to supplement whatever they are getting. And also the head-up position is great to prevent secretions and to help prevent atelectasis. As in the immediate post-op period, we can continue the regular nebulizer therapy with additional bronchodilators as needed, depending on the clinical state of the patient. And then from there, in the patient is back to the ward now, review the dose and administration of both the bronchodilators and the steroids. And then always important um, to keep analyzing the patients. If there's increasing dyspnea and wheeze, it's also possible to consider other contributing factors and treat as necessary. So in conclusion, it's important to remember 4 key points in the perioperative management of anesthesia. We need a thorough understanding of asthma, which is what we talked about. What are the causes? What are the risk factors? What are the triggers? And what is the general treatment? The proper preoperative management, the preoperative evaluation, which is critical to determine the treatment in the perioperative period, intraoperative vigilance to identify and treat airway events early, and prompt recognition and early recognition of asthma exacerbations, both in the on-table period and the immediate post-op period. So being knowledgeable about this is important to properly manage a patient with asthma perioperatively. These are my references, and thank you for listening.
Okay, so thank you, Dr. John Apam Osman, for the wonderful presentation. So the presenter, he started by defining asthma, and he mentioned three key features of asthma, which are reversible airway obstruction, airway responsiveness, and inflammation. We went ahead to listing the signs and symptoms of asthma and give the classification of the asthma into mild, moderate, intermittent, and then severe asthma based on the frequency of the night symptoms and then the peak expiratory flow rate all over forced vital capacity ratio. Then he mentioned the general consideration for a asthmatic patient coming for a surgery. Now mention the pre-operative optimization, intraoperative management, making more emphasis on management of bronchospasm in patient intraoperatively, and then you mentioned some of the consideration during the postoperative period. And then you went ahead to conclude. So now uh, we can entertain question, comment, and contribution. But before that, I would like to recognize the presence of some of our trainers who come in during the course of the presentation. Dr. Aderonke Adeshian, Professor Alasan Betty, Professor Elizabeth Unwaso, and other consultants here present. You are all welcome. Thank you for finding time to join us. So now going to the question and comment section. From the chat box, somebody asked, thank you for the presentation, sir. Please, why do we do a coagulation profile for asthmatic patients?
Okay.
Dr. John.
Thank you for the question and comments. They are well received and noted. Coagulation, like I said when I was mentioning it, is not specifically for the asthma itself. For the patients with asthma, it is if indicated in the surgical procedure that you're about to perform. Although it definitely will have investigations, generally will give you information about the patient, so it's a positive. However, the coagulation profile that you're checking is not specifically for the severity of asthma or for the asthma patient. It's for the general consideration of the patient, even maybe the surgery the patient is about to go through, maybe it's ENT or MFU surgeries or neurosurgery that requires those as the part of the investigations. So maybe not specifically for the asthma, but in asthmatic patients too, it's also good to have this complete picture to ensure that we are not missing out anything. Thank you so much for that question.
Okay. So another comment by our trainer, Dr. Aderonke Adeshan, she said, well done, Dr. Afam. Thank you very much, ma'am. Then
Thank
somebody
you very
asked, thank you sir, for the presentation. Very educative one. How can we get the slide? The slide will be shared on the NSA resident page. So you
Yes.
can up there after the presentation. So this one, thank you for the presentation. Please, you mentioned your analysis as part of the investigation. Please, what is the relevance? So relevance of your analysis,
Okay.
asthmatic patient.
Thank you so much for the question. I think same thing I was mentioning the coagulation profile. The specific investigations for the asthma would be the spirometry, the peak expiratory flow ratio, a chest X-ray, ECG. Those would be the ones that are quote unquote specific for the asthma. The rest, full blood count, electrolyte, urea, creatinine, fasting blood sugar, urinalysis, coagulation profile is more for the clinical condition of the patient itself to set a baseline and also for other information about the patient. So not specifically for the asthma as much as to get the general clinical condition of the patient, especially one that you're taking to theater. Thank you.
So thank you for the presentation, sir. I want to request a clarification. I suppose the peak expiratory flow all about FEV1 predicted in the severity table means either PEFR or FEV1 percentage of predicted for the age, height, and sex, not PEFR over FEV1 predicted. That is PEFR or FEV1 measured for the patient over the predicted, that's calculated or machine generated value for the same patient multiplied by 100. So it's seeking clarification over that
Yes.
table that give the
Yes,
severity.
thank you so much, Dr. Olowo. Yes, that is, thank you for noting that. That is what, I mean, we all know will I say the severity classification. So yes, you are in order, sir. What you said is correct. Thank you so much.
Okay, so this one said, kindly explain why halogen need to be discontinued or avoided when anticipating for use of adrenaline. Thank you.
Okay, thank you, Dr. Akimbola, for that. So halothane sensitizes the heart to catecholamines. It increases the likelihood that there will be an arrhythmia or a significant arrhythmia with catecholamines such as adrenaline. So generally, when you're anesthetizing a patient, you're using halothane as a maintenance agent. If the patient also is going to have adrenaline administered, you hear it sometimes, maybe when the surgeon wants to infiltrate with adrenaline, they would inform you and then you have to cut off the halothane. So for that same reason, because halothane at a mark of greater than 0.5% has been seen to increase the sensitivity of the heart to these catecholamines. So as such, it is best practice or better practice to either cut off the halothane if you're anticipating the use of adrenaline or reduce it to a mark of less than 0.5. This effect is also seen in a much lesser way with isoflurane, but isoflurane is generally considered safe with adrenaline. I hope that explains that. Thank you so much.
So thank you for the presentation, sir. Please, are there any further consideration for patients with asthma/COPD overlap intraoperatively?
Oh, thank you so much for that question. Further considerations for patients with asthma and COPD overlap. Generally, it will fall into a number of considerations. First, in the preoperative period, these patients would be less optimal. So they already have the COPD. As such, they would have maybe increased respiratory concerns, a hyperinflated chest, all those issues that we see with COPD. And patients who already have respiratory issues pre-operatively have a much increased risk of respiratory issues perioperatively. So if a patient already has COPD established and is managing that before the surgery, there's an increased likelihood of airway events both in the immediate pre-op and immediate post-op period. So for all these patients, you would first obviously have to be more on the lookout. All the precautions we mentioned, airway instrumentation, the drugs that you have available will be there. And extra in the immediate post-op period, they might require oxygen supplementation or even management in the HDU, maybe not the ICU, except they have extreme perioperative events or adverse events or delayed recovery. But they could need continued oxygen supplementation or even further management in the HDU. For some of them, they could have respiratory insufficiency. So you could even consider maybe using a CPAP in that recovery period, depending to increase oxygenation and ensure that they don't have any respiratory issues. I think maybe what I would do, I would outline after this, and I'll send to the group a details of the anesthetic considerations for patients with asthma and COPD, just as a bullet points, a few bullet points, and I'll send to the group. Thank you, Dr. Etuk.
So thank you very much. At this time, we'll give room for our trainers that are here present to make their own comments and contribution. You are all welcome, sir and Matt.
Hello, can you hear me?
Yes, sir.
Yes, sir.
Welcome.
Good evening,
I
sir.
think you can call on Professor Nwaso. I think she's been around from the beginning. I joined rather in the middle and I was actually dozing off, but I have comments to make in case it's not addressed by Professor Nwaso. And then after her, there is Dr. Adeshian. We allow her to say something too. Thank you. Professor Nwaso.
Thank you, Mr. President, Professor Detti. Yeah, actually, I think I've been here from the beginning. It's been a very good, well laid out presentation, and I think they are also handling the questions very well. I just wanted to say that steroid use in the perioperative period um, is good. It is being advocated because it has a lot of positives to it, and it also reduces the airway hyperactivity or reactivity. So things to do with response to laryngoscopy and intubation and laryngospasm and all that can be checked. I just saw a question in the comments that said, "Can you comment on steroid use perioperatively? When to stop? How to convert from one form, and when to restart post-operatively?" So that was just what I was responding to. Now, there are different steroids that can be used, like dexamethasone is one of the common ones that we tend to use, at least for anesthetists in the intraoperative period. So doses are usually calculated, but I have the thumb rule that for adults, I tend to give 8 milligrams, and you can also give it in response to maybe something that's happened in the intraoperative period, and you don't want the patient to have an adverse event. In that case, you can even give up to 2 times of 8 milligrams. That means you can give up to 16 milligrams. There are many calculations in the literature of how to switch from one to the other, but for the thumb rule, I only use hydrocortisone and dexamethasone in the perioperative period. For the hydrocortisone, for adults, I tend to give 200 milligram as a start dose, and then hydrocortisone. The advantage of hydrocortisone is that it tends to have an immediate effect, whereas Dexa might be, slow in having its onset of action or efficacy. But that's what I can say about that for now. I also want to comment that I expected more attendance from the participants. Surprised the attendance is not very good like the previous ones. I don't know what could be responsible for that, but I want to encourage the residents, the trainees, that these peer driven activities tend to be very good with a lot of positives in terms of learning. So people should make very good use of this opportunity to be able to get maximum benefit from it. That's my comment for now. Thank you very much.
Thank you so much, Ma.
You're welcome.
Dr. Adeshian, if you're still around, please.
Thank you, sir. Thank you, President, and thank you so much, Ma, Prof. Nwaso, for your comments. I just wanted to add that In children, special caution should be applied because for obvious reasons, and that it's been advocated that you minimize airway manipulation and stimulation. So what that means is that you make sure that the process of intubating these patients is as smooth as possible. It's not time to teach when you have an asthmatic child on the table during the intubation. So you minimize the time and the number of attempts. Then it's also been advocated that if it's possible to avoid intubation, supraglottic airway devices are preferred to minimize that stimulation of the airway. So you also, studies have shown that the incidence of bronchospasm and aspiration is not much more in the supraglottic when supraglottic airways are used for this category of patients. And finally, I want to say that a patient being asthmatic doesn't mean they're also not prone to other issues that may cause wheezing. So not all wheezes are asthma. So you have to also, if you've tried all sorts of intervention and it's not working, you need to look at other things like anaphylaxis, aspiration, foreign body aspiration like a tooth or a piece of medical equipment, other causes of upper airway obstruction. So you need to troubleshoot. These patients, it can also result from the asthmatic attack, but if you've tried everything and it's not working, you need to look at other things as well. Thank you.
Thank you very much, Dr. Adesina. Before I make a comment, for the residents that don't know this, Professor Nwaso Anaesthesia, Professor Nwaso is a past president of Nigerian Society of Anesthetists, and Dr. Adesina was one-time secretary of this association and the immediate past president of Society of Specialists in Airway Management. That's why she was telling you she has to talk about that airway. So really, the perioperative management of the asthmatic patient is really an interesting one. It will task it will test your skills, your recognition of that life-threatening condition, laryngospasm. Now, let me give you some practical tips. You should know that the asthma, you should know that it's common in children and adults. This you should know. So don't say because this presentation is not only for adults, though I didn't listen from the beginning, but towards the last third of the presentation and also the questions and answers, which was done beautifully. So you should know that. Now, from the practical point of view, I have learned over the years to always listen to the chest of the asthmatic patient. Even just recently, one of my senior residents, she was good, she handled it. She had issue and we didn't know that, we knew she was asthmatic, but we couldn't hear, there was no obvious wheezing. But that rhonchi was there, So that's to tell you, either you have to defer the case if it's not emergency, or you have to take some measures. So always remember that. Then take a look at your full blood count. Now, I want to tell you, don't go looking for it, please. But in the course of reviewing a sentinel event, I was looking for the cause of the bronchospasm or laryngospasm. And I stumbled on an explanation. When you see, in the full blood count, you want to see eosinophilia. You may not see it, but when you see monocytes, the range is 0 to 6. So when you begin to see monocyte 2, 3, they are heralding the appearance of eosinophils, meaning that that airway can be reactive, hyperreactive, honestly. It's there. But this is just for you, for your practice. Now, the most important thing is recognition. Now, the attack can come either preoperatively, intraoperatively, or postoperatively. Now, even the rush of air can trigger an attack. Now, when they present to you, it's important to also check what was, the medication. If these days they give corticosteroid, right, to prevent. Now, if they are on long time, if they've been taking it for long, now, and the procedure, potential blood loss, be very careful. Why? Because that corticosteroid may have suppressed the adrenal. So this patient, when there is blood loss, acute blood loss, may not be able to mount enough response. You remember the response to trauma, renin, angiotensin, aldosterone system. You may not have that. And that is the value of perioperative steroid, in line with what Professor Mwaso was saying. So whether, for me, I give hydrocortisone, number one, to stabilize the mast cells, whether the last attack was 10 years ago, all right? And I give it 24 hours, 6 hourly. We give that, and I follow up, actually, because they can still have attack post-operatively. Secondly, if, like I mentioned earlier, if the patient is on steroids for long, you can expect suppression of the negative feedback. The body will say, hey, we don't need this, more of this. But when the body needs to mount a response to acute blood loss, you can have a cardiovascular collapse. All right, so this you should take note. All right, then you must be able to, that's where, when you have laryngospasm, that's where you test your airway management as well. So that basic airway management that you see like it is bread and butter, that is a basic skill that you must always be ready to employ. Now, when you are anesthetizing asthmatic patient, please take note of what was the, let's say, is a major case, is a GA, you have intubated, paralyzed, so we control ventilation, and the airway pressure on your anesthetic machine, please keep an eye on it. The first thing you see, if you hear a change, from the sound, or you see that there is a drop in the saturation, always look at the airway pressure. When you start with 15 centimeters of water and suddenly moves up to 25 within a short time, take some measures. Increase the FiO2, listen to the chest, rule out other causes of sudden increase in airway pressure, tube kinking, or somebody stepping on the anesthetic circuit and so on. So please take note of that. It's always there. The risk of this happening is always there. Thank you. So I don't know if there is any other comment, but by and large, it's a beautiful presentation. Having had the last third of the presentation, and then also the way the presenter handled the questions, which was very good.
Thank you so much, sir.
Yeah. So is there any other thing?
No, sir. I think that is it.
Okay. So we want to thank, because I didn't see the chair here. Sorry, Professor Nwaso, the consultants that you don't see, I can say that the consultants are in Sokoto, ASCAP, and then the residents around that area too, probably that may have contributed. But
oh, I see.
yeah,
I didn't
and
factor
then
that.
yes, I didn't have time to share with our respiratory unit usually I send to those who I know. And yes, so they are interested, they can. So
Okay.
that may have, and I didn't have time to share with my friends in the East and Central Africa. They're always looking forward to these presentations. So that may
Yeah.
have explained. Yeah. So next time I
Okay.
promise the number will double, but
Okay.
I think it's a good presentation. Yes.
Yes.
Yeah. So
Well
thank you
done.
very much, everyone. Exam, this is August. There is exam this month for those going for, because they ask everything CBT. So every presentation, I've learned one or two things here. Wherever there is a presentation, anything, discussion, there's always something to learn. Even when you have had this many times, once you have time, please listen. There will be one or two things that will be added, which you will learn. So I want to thank everyone. And when is the next presentation? And do we know the topic?
It's in 2 weeks, sir.
In 2 weeks' time.
Perioperative
Okay.
cardiac events, cardiac arrest in the perioperative period.
An interesting one. It is good because that will stimulate them to know that in the exams, the OSCE, you can always, there is always a CPR table station, right?
Yes.
so please read around and come to learn. Then I'm sure there are also practical sessions through some workshops and so on. And many of our training institutions are doing BLS CPR training regularly. So we shouldn't miss that. Thank you very much, and bye for now. See you in 2 weeks' time. Thank you.
Thank you,
Bye. Thank you.
sir.
Bye
Thank you.
bye.
Thank you. Thanks, everyone.
Thank you, Prof.